as you get the, so you'll be asked to say okay, and if those of you who don't want to be visible, then you can keep your videos off. But as I said, thank you for attending today, and it's going to be a very engaging session as well. We've got, our really lovely and honoured to have our consultant, Dr. Dejo from the University Hospital Leicester. So, he's given up his time today, so really glad to have him. Without further ado, I'm going to hand over to my colleague Keval Sachdev, who's actually coordinates our Cancer Community Connectors project. So I'll let him start introducing the project. Thank you.
Hi, good morning. Thanks, Kiri. And yes, thank you, Dr. Dejo, for joining us today, taking time on a Sunday morning. This is session 3 of our SAHA ACE Community Cancer Connectors project. The first session was a launch session to introduce the project. Second session, the last one, we tackled myths and taboos, stigmas surrounding cancer. Today's theme is recognizing symptoms, and we're also raising awareness for World Head and Neck Cancer Day, which Kirit will speak about a bit later as well. We've also got a specialist with us, Dr. Dejo. Again, thank you for joining us today. That is one of his specialist areas, so he'll be speaking more about that as well. What I just want to do, I'll just quickly share part of the presentation we've got, and we're lucky enough, again, thank you to East Midlands Cancer Alliance and the NHS as well, ICB and other local organisations who've supported us, obviously our Community Connectors team and our guest speakers today, who we'll hear more from later on in the session. So we've got a lot of people to thank, but again, this is a community project. The aim is to help people in our community, and it's based around Leicester, Leicestershire and Rutland. So we will be having sessions elsewhere around Leicester in the future, covering different themes. The next one in August is navigating the healthcare system. So all of you that have joined us, if this is the first time you're joining us, if you can in the chat put your email address, or we will be sharing our email address soon on one of the presentations. You can email us at connectors@sahauk.org, and on there what we're going to do is get everyone a registration form for anyone who wants to be a community connector. So I'm just going to start a presentation. I'll try and share my screen, so bear with me. And we're lucky enough, we've got some videos supplied to us by the NHS and EMCA, again, covering the topic of recognizing symptoms and why it's so important that our community not only understand the symptoms, but also what they need to do, who they can go to, and where they can seek support from. So we're just going to get into the presentation. Just bear with me. Okay, can you see that, Kiri? Kiri, can you see that?
Yes, sorry, I can see that. Can you just put it on your, if you go on the presentation right to there's 4 boxes, it says slider view. That should be perfect. No, you've gone back to your original screen.
Sorry, which one did you want me to press?
Yeah, so on the bottom of the presentation, just there's basically, it says slider view. But if not, just carry on. Start with the first one.
Okay, so yes, this is today's theme. It's recognizing symptoms and also recognizing World Head and Neck Cancer Day. This is a bit about South Asian Health Action, our vision statement and our mission statement, and what we aim to do in the community. We can obviously share this. This presentation will be available for all community connectors, so we will be sharing this. We'll also be running some training sessions starting very soon, so please do, like I said, send us your email address and we can send you details of that. This is the first video that we've got supplied by EMCA and the NHS, so I'll just play that now for you.
What is the biggest preventable cause of cancer after smoking?
Oh goodness me.
Oh, I don't know. Drinking?
Sunbeds?
No? Well, open that and it will tell you.
Oh, is it? Oh, really? Oh, right, wow, okay.
Yes. Obesity. Yeah. Oh.
Needs to be like more said about that, because you wouldn't think you give your kids chips and what have you.
Same as the cigarette package when they say stop smoking and things like that. The same sort of thing applies to the food, surely.
There's a lot of obviously generations that are coming in now that don't really know as much.
What is the biggest?
Most people who are diagnosed with kidney cancer don't have any symptoms. They might be having a scan for other things and it shows they have a kidney cancer. This is called an incidental diagnosis. Their cancer has been found by chance when investigating something else. But when someone does have symptoms, these might include blood in the urine, a lump or mass in the kidney area, as well as pain in the side between the ribs and hip. This is known as the flank area. In this video, we're going to cover the potential signs and symptoms of kidney cancer in much more detail, and we'll also discuss when you need to see a doctor and what might happen when you go to visit them. So first of all, let's discuss three of the most common symptoms and signs of kidney cancer, the first being blood in the urine. So blood in the urine, which is called hematuria, is the most common symptom of kidney cancer. Now it can also be caused by other things such as infection, enlargement of the prostate, or kidney stones, but it's always important to see your doctor if you see any blood in your urine. Now, the blood doesn't have to be there all of the time. It can come and go. And sometimes the blood can't be seen by the naked eye, but your doctor can do a simple urine dipstick test to check for this. The second important sign to note is a lump or mass in the kidney area. This is the area of the body where your kidneys are, and if you feel a lump or swelling in the area of your kidneys, you should always see your doctor. Now, most kidney cancers are too small for you or your doctor to feel, but your doctor can arrange for a scan, such as an ultrasound scan, to check for cancer. Now, the third thing to note is a pain in the side between the rib and the hip. This is known as the flank area. A pain in the side between your ribs and the hip, which is the flank, can be a sign of kidney cancer. The pain may also go around your lower back, but just because you've got pain here does not necessarily mean you have kidney cancer. Pain in these areas can also be caused by other things like an infection or commonly kidney stones, but you should always see a doctor if you keep getting this pain or it doesn't go away. Now, in addition to these three signs and symptoms, some people have got other symptoms which can be vague. These are things like losing weight without trying to, a high temperature and very heavy sweating, tiredness, a loss of appetite, and general feeling of poor health. High blood pressure and having fewer red blood cells than normal, which is known as anemia, and it can be detected through a blood test, can also potentially be a symptom of kidney cancer. Now, these symptoms are related to the hormones that the kidneys produce, and it can cause your blood pressure to be extremely elevated. Now, it's important to know that all of these symptoms can be caused by many other conditions. Most people who've got these symptoms will not have cancer. But if you do have any of them, it's important to see a doctor. That's because if it is a cancer, it will be much easier to treat if it's diagnosed early. Finally, when should you see your doctor and what might happen at your doctor's appointment? Well, it's important to see your doctor if you notice any of the symptoms that we've discussed. So these are blood in the urine, a lump or mass in your kidney area, or pain in the side between your ribs and the hip, so the flank. Any other symptoms of kidney cancer that don't go away should also be discussed. These include the vague symptoms like losing weight without trying to. Now, depending on your symptoms, your doctor might do a general physical examination. They're going to feel for any areas that might be swollen or not normal. They may also listen to your chest to find out if it sounds normal, and they might ask you to provide a urine sample so they can test it for blood or an infection. They may also arrange for you to have blood tests either there in the surgery that day or to come back later on to have the blood tests. Now, after your examination, your doctor might want to refer you to hospital for other tests, things like an ultrasound scan, or they may even refer you directly to the specialist. It's important to ask your doctor to explain if they don't think you need a referral or any tests and their reasoning behind this. They may ask you to come back in a week or two if your symptoms continue, but it's also important to go back sooner if the symptoms change, get worse, or don't go away. Sometimes when you do see a doctor, you might be nervous, anxious, or worried, and you might forget to ask all of the questions that you wanted to. Don't worry, this is totally normal, but it might help to bring a friend or family member with you and write down some of the important questions that you want to ask. These might be things like, do I need any tests? And what day involved? Will I find appointments by post or telephone? How long should I expect to wait? Where can I find out more about the different tests? Do I have to do anything in preparation for the tests? And do I need to see a specialist? As well as who do I contact if my symptoms change, continue, or get worse? And when should I see you again if this happens? I hope you found this video informative and helpful, and if you did, please consider liking it, subscribing to the channel, and sharing it with a friend or family member who you think might benefit from this. If you also want to share your own experiences or comments around kidney cancer in the comments section, please do so. This can be incredibly helpful for other people watching this video, and until next time, bye.
Thank you. So that was a video shared to us with from NHS and EMCA. We've got many more videos that we'll be uploading to our new YouTube channel, which we'll be sending a link out to all of you who have joined us and to other people in our networks. These videos will be uploaded, and the important side of it there was to discuss what happens when you get symptoms, what kind of questions are asked, and obviously how simple some of the tests can be. So many people tend to be afraid when they do find symptoms. They either tend to put off biopsies or tests, or they don't chase up their appointments, or sometimes don't even attend them. They even find it difficult talking to families, which is why we've got this session, especially around recognizing symptoms. What we'll do is it's time now to speak to Dr. Dejo.
Just before that, Kevin,
sure.
just for people who have obviously first time coming to find out about the Cancer Community Project, it's just to let you know that we've been working prior to the current project. We've been working as part of the NHS Core 20+5 Health and Equalities Programme, and the three areas that we were working on were early diagnosis of cancer screening, hypertension, respiratory. And what we clearly found from that project was we were trying to recruit people from the community with the lived experience, and luckily we've got a number of lived experience cancer connectors, hypertension, and also respiratory connectors who form part of our journey. And then since January of this year, we've got a project funded through East Midlands Cancer Alliance, but supported by the NHS ICB, to focus solely on recruiting more cancer connectors, but looking at raising more awareness of cancer early diagnosis screening. So that's the kind of background of where we are today in terms of the project that we are working on. And the videos that we've shown, that Kevin just shown, part of the project is to kind of produce some more culturally relevant, appropriate videos from our communities, again in different languages. So throughout the course of this project, that's something that we would welcome your engagement and support on as well. So that's so we realized that some of the videos are great, but they're not. We need to make them more tailored to meet our community needs. So without further ado, again, I'll let Kevin introduce our next speaker. So thank you.
Thank you, Kiri. So, Dr. Dejo, I believe you had a presentation to share with us as well. First, we'd just like to welcome you, first of all, and thank you for joining us. Can you tell us a little bit about the work that you do?
Good morning, everybody. Thank you so much, Kirit and Kevo. Thank you to the South Asian Health Action Group for your kind invitation to speak to you today on World Health Head and Neck Cancer Day, talking about the symptoms of head and neck cancers, the risk factors, the sort of treatments and prevention. So yeah, it's a real great privilege to be here. In particular because it's been really nice working with Kirit and SAHA. You're a very organized, responsive group. I've had the privilege of working with SAHA as an Oracle head and neck ambassador, who are a leading head and neck cancer charity in the UK, led by Chief Executive Tamara Khan, and working with Dr. Naina Patel, who's been an incredible resource person and link with our ethnic communities in Leicester, trying to reduce health inequalities. It's great to collaborate with my colleagues from the UHL on cancer conversations that affect us, that affect the Asian communities, the Black communities disproportionately. And I do want to say thank you to some of my colleagues present, Dr. Lubukola Ayodele, who's a consultant medical oncologist and who leads the breast cancer team in UHL. She's been working with SAHA as well, so raising awareness around breast cancer in Asian and Black women. So the work that I do, I am a consultant head and neck and robotic surgeon at the University Hospitals of Leicester. This means that my life's work is to look after patients who have cancers of the head and neck area, the throat, the tonsil, the back of tongue, the voice box, lumps in the neck, thyroid cancers. And I get to remove these cancers completely with surgery, open surgery, endoscopic surgery, and with the robot as well. And the point of all of that is to take the cancers out completely, get our patients through that treatment phase, and return them back to their families and their friends. That is the whole purpose of why we do what we do. And some of those treatments can be really challenging, the impact on patients, radiotherapy and surgery. And I've found in my work that early cancer diagnosis saves lives. It makes a massive difference if people present on time. And how do people present on time? We need to know what symptoms to look for, and how to speak to our GPs to say, I have found a lump in my neck. It's not gone away in the last 3 weeks. Could you please refer me urgently to the hospital? And it is work like this that really moves the needle and ensures that people present early. And I'll be working with SAHA particularly on the risk factors, chewing tobacco, in particular chewing pan, gutka, which are cultural. The cultural pastimes in the South Asian community, and I want to work with you to better understand how can we together tackle this problem and reduce cancers of the tongue and cheek and throat area. So today is more a conversation, sharing what I know about head and neck cancers, the symptoms that you should be looking out for, the risk factors that we know, and prevention. In particular, the human papillomavirus vaccine, which I will talk about because the uptake of the HPV vaccine is low in our Asian communities and Black communities, for lots of different, cultural reasons and mistrust and lots of different things that we're worried about. So I'm hopefully able to reassure us about that. But the HPV vaccine is incredibly important in preventing cancers of the cervix, which a lot of women would have, preventing cancers of the tonsil, of the throat as well. So it's really important that we engage with that prevention arm of things. So really, this morning is more a conversation with the South Asian community around what are the symptoms you look out for, what are the risk factors in our communities, particularly pan, gutka, tobacco chewing. How can we together tackle this problem and raise awareness? And then how can we raise awareness around HPV vaccination? So that really will be the core of what I will be talking about today. I've given you the talk in 5 minutes, and now I will share my slides. Are there any other questions, Kevin?
Yes, we did have a question in the chat actually.
Okay.
So thank you. It says, can difficulty in swallowing something like bread, either toasted or otherwise, without taking a sip of water or drink be an early indicator at all, or other factors come into play? I think,
yes.
Thank you for that question.
Yeah, thank you so much, Rani Mahal. I acknowledge your question. And yes, you are right that difficulty in swallowing is one of the symptoms to look out for. Most people have difficulty in swallowing at some time or the other. If you're eating bread or something dry, you need to drink water and fluids. That doesn't mean you have a cancer. That is common. Everybody goes through that phase. The older you get as well, your swallowing muscles get weaker, and you get what we call globus sensation, a feeling of something stuck in the throat when there isn't actually anything there. But the things to look out for, which I'll talk about in my talk, is when those symptoms last more than 3 weeks. If you're getting persistent difficulty swallowing, pain on swallowing, a lump in the neck, a change in the voice, losing weight, all of those sort of symptoms together should make us go to the GP. So 3 weeks, persistent symptoms for 3 weeks, not going away. Please go and get checked out at your GP. There is an urgent cancer pathway, which means that when the GP gets those symptoms that you've described lasting more than 3 weeks, it is the GP's duty to refer you urgently to the hospital. So we will try and see you within 2 weeks of getting a referral from your GP. But, so difficulty in swallowing, yes, whilst it's a symptom, but it is a common symptom, which does not mean that you've got a cancer. It's got to be persistent for at least 3 weeks, and there could be other symptoms. So thank you, Rani, for sort of prefacing what I'm about to start talking about, which is really important. So thank you. So I'm going to share my slides now, if that's okay. Let me see if I can.
Perfect. We can see a nice, lovely picture in the beach somewhere.
Incidentally, and subsequently then apply for one dwelling, then we'd be looking at about 80 to 90,000 pounds in costs.
I wish I was on the beach, but so that was a bit.
Sorry, before you start, can I ask people to mute themselves so we don't disturb the presentation? Thank you very much.
No, thank you so much, Kirit, for that. I was going to say that was a beach in Adelaide when I went to learn how to use the robot to remove throat cancers. So today it's World Head and Neck Cancer Day. As I've said, I work as a head and neck and robotic surgeon in the University Hospitals of Leicester. I work as part of a big, incredible team, our head and neck cancer team. Oncologists, surgeons, speech therapists, dietitians, pathologists, radiologists. I am part of a massive village. It takes a village. So it's not just me, although I'm here speaking to you. I represent a really incredible team of experts who look after cancer patients. It is our joy and our privilege to look after cancer patients and get them better. I lead the Head and Neck Cancer Research Institute in UHL as its director, and I'm an honorary associate professor at the Leicester Cancer Research Centre in the University of Leicester. And one of the things we want to do is increase research participation with the South Asian group, cancers, diseases that are specific and that affect the South Asian population disproportionately. We really do want to work with you to understand the better treatments. So today I'll be talking to you. I'll share a bit about the anatomy of the head and neck, because I imagine not a lot of us are familiar with it. The epidemiology, what are we seeing in the communities and across the country? The risk factors, in particular, chewing tobacco that I've talked about, pan and gut care and smoking tobacco and shisha and things like that. But in this bit, I really want to listen to you at the end of the talk for you to educate me about pan and what is inside it and how can we get tobacco out of it and how can we raise awareness. So this is something that we would like to work with SAHA on. It is help that we're asking for from you. What the symptoms are to look out for, as has been mentioned already, how we prevent it. I'll talk about the HPV vaccine, the treatments that we currently have, and the raising awareness. So a little bit about head and neck anatomy. So quick warning for those of you who might not like pictures and things. I'm going to show you, some basic pictures around the throat area and things. I will show you pictures of what you see when we put the camera up the nose into the back of the throat, so you can see what the voice box looks like and the back of the tongue looks like. But I will also show you what some of the early cancer changes look like. So please be aware that there will be some pictures that will show you what you're looking for: a white patch on the tongue, a red patch on the tongue, a little raised lump on the tongue, something inside the cheek. I'll show you some of those pictures so we can discuss in context. If you look at the side of the head, you've got the whole head and neck area from the nose the sinuses, the mouth, the tongue, the voice box area down to the swallowing area. These are the areas that we are talking about. I've got lots of pictures, okay, just to make it easy for us to follow. So it's just about pictures. So when we go up the nose, there are side cushions in the nose. We call them turbinates. They're like air conditioning systems to humidify air as it goes into the nose. There's the back of the nose area where your eardrums, your ears open into the back of the nose. In that area as well, cancers can develop there, particularly in people from the Far East. There are dietary things that can predispose people to it. Cancers can develop in the sinuses in people who work, with chemicals and are exposed to dusts and things like that. So we just need to be aware. When we do a scan of the face, this is what we sort of see. These are the sinuses. So you wouldn't see this ordinarily when you look at someone, but when you do a CT scan, these are air-filled cavities between the eyes. We call those ethmoid sinuses. In the cheekbone, we call those the maxillary sinuses. And at the back, close to the brain, you've got the sphenoid sinuses as described. So all these areas help you to speak, help sound to come out. But sometimes, you can have sinusitis, which is just inflammation. But sometimes there can be a mass. And when there's a mass or a lump or a swelling in the sinuses, you may struggle to breathe. You may have nosebleeds not going away. There might be a swelling in the face. The jaw could swell up. So it's important to understand this anatomy. Now, this bit here, you can all see when you look in your mouth in the mirror in the morning, or you look in your kid's mouth. This is what you see in the mouth, the tongue. But it's important to look on the side of the tongue as well. That is particularly for people who chew tobacco or chew pan or chew gutka. The side of the tongue is where often you can see a white patch or a red patch, and there's an issue. The roof of the mouth as well, we call that the palate area, hard and soft palate. When you look at the back of the tongue, the sort of middle bit is called the uvula, and then the sides, they're like little oranges in the back of the throat. They're called tonsils. So lots of people get tonsillitis and sore throats. That's okay. But if you're having a sore throat and struggling to swallow for more than 3 weeks and it's not going away, then you need to go see your GP, because it could be a cancer of the tonsils that I'm showing you here. And this is actually quite important, because we are seeing a lot more patients presenting to hospital with tonsil cancer or back of tongue cancer. And a lot of the cancers in this area have been driven not just by smoking, but also by this human papilloma virus. So the human papilloma virus is the same virus that causes cancer of the cervix in women. We've known that for many years, and we've been vaccinating girls in the UK since 2008 to prevent cancers of the cervix. But we are seeing more men, younger age, who are coming to our clinics with cancers of the tonsil, cancers of the back of tongue, that are caused by the human papilloma virus. It's sexually transmitted, and therefore there's an awareness that needs to go out into the communities about the human papilloma virus vaccine. Your children get given the HPV vaccine in school when they're age 12, 13. Previously it was only girls, but now the government is giving girls and boys, precisely because we're seeing cancers of the tonsil, this area I'm showing you, in men who don't necessarily smoke or drink. So keep your mind on that, because I think we do need to talk about human papilloma virus and the vaccine, because it's preventable. I'll show you a few pictures about what the throat looks like when we put a camera down. So when we do see patients in clinic, we could put a camera up the nose. It can go all the way to the back of the tongue. We look at the voice box area. It can go even all the way down into the stomach. And anything that looks abnormal in those areas, we can take biopsies of. And we can do that with Urowake. We could do that with a bit of spray, local anesthetic, 10, 15 minutes, and patients can go home. So there really isn't anything to be worried about coming into hospital, is the point I'm making. So when we put the camera up the nose, I do this for everyone in clinic. The back of the tongue, that's what it looks like with the tonsils, the back of tongue area. There's a flap that covers the voice box called the epiglottis. And then the vocal cords are You can see them beyond the flap. That's where the voice comes from when we speak. So these are the areas that we look at, and this is all normal, apart from, there's a little cyst that I've put there so you could see normal and what abnormal might look like. This is the voice box. You can see the flap that covers the voice box, and you can see the vocal cords. Now, people who smoke tobacco or chew tobacco, they are at high risk of getting cancers of the vocal cords. So what they will see are changes in their voice. So they may get hoarseness, and they might start speaking like this, and you think, hang on, what's wrong with your voice? So if you notice that your voice has changed, or they may start struggling to breathe, shortness of breath, they might get pain. They might get pain going to their ears. We call that referred pain. They may struggle to swallow. So it's because there's a cancer in one of these areas. What I'm showing you now is normal. So I'm just showing you normal for now. I will show you abnormal pictures in a minute, but just so you begin to understand what the voice box looks like. So there can be a cancer on any of these structures that you see in the voice box, in the flap that covers the voice box, the top end of the swallowing pipe. And we can easily see it in clinic when we see you, when your GP refers you within 2 weeks with a little camera up your nose on the local anesthetic, and you go home within 30 minutes. So the examinations are pretty straightforward. I'm going to talk a bit now about epidemiology. What are we seeing out in the populations and in communities? So we know that head and neck cancers are the 4th commonest cancers in men, and the 7th commonest overall. The critical thing here I wanted to be aware of is that almost 60% of these cancers are diagnosed at late stage. People are coming when I can't operate on them. The surgeons we say, look, this is late stage. And by late stage, we mean the cancer has spread and has invaded the voice box or the back of the tongue, or it's gone into the neck, or it's spread to the lungs or the spine or the abdomen or the liver. When we catch cancer early, patients survive. I want us to remember that early cancer diagnosis makes a massive difference to survival. So when we see a patient and we look at the cancer and we do scans, we're checking the whole body to see if the cancer has gone anywhere else. If it has spread, the chances of survival drop significantly. And there are ways we stage cancers. When patients come in late stage and it's spread to the lungs and the liver and everywhere else, then we won't offer them surgery. And even the sort of treatments that are offered, maybe chemotherapy or radiotherapy, are not to cure the cancer in most cases. They're to support the patient. It's almost like supportive care that we're given. And therefore survival is reduced. Take, for example, if someone came with an early stage tonsil cancer, someone goes to their GP and says, I've had a sore throat for the last 3 weeks. It's on the left side. It's not going away. It's painful when I swallow. There's a lump in my neck. They go see the GP. The GP refers them. I see them within the 2 weeks. I say, you have a tonsil cancer. I do some scans, CT scans and MRI scans. I take you to our multidisciplinary team and we say, this person has an early stage tonsil cancer. What will happen is I will talk about using the robot to remove that tonsil cancer. And it means I can take it out completely. And the massive difference there is the cancer is gone. The patient, therefore, does not need radiotherapy or chemotherapy, often if it's an early stage. Now, if the same patient waits another 3 weeks and says, well, you'll go away, I'll just use this little paracetamol and some herbs, some traditional lemon and this and that, and then, goes 2 months later, we're now 8 weeks in, GP then refers, and then we see, and then we do all the scans, and the scans come back and say, there's a tonsil cancer, but it is really big. It's gone into the tongue, it's gone into the jaw, it's spread to the lungs. I can't offer that patient surgery. It's going to be left to my oncologists to say, we can still give radiotherapy, we can give chemo. The chances of survival have now dropped from 94%, where they would have been if the patient came in early and had early treatment, to 46%. It's a massive drop. And we know that, but so it's important that we get the message out to our communities. When you notice any of the symptoms, sore throats, difficulty swallowing, neck lump in particular, change in voice, losing weight, please go see your GP, particularly if it lasts more than 3 weeks. I will keep saying this because today, this is the message for today. Everything else is just pictures. If we get this message out, I think I'll be happy. Now, 50% are actually preventable. You know, we've talked about the human papillomavirus vaccine. Allow your children to be given the HPV vaccine. It will protect them against throat cancer, cervical cancer, genital cancers as well. And it's effective. We have seen like a 90% effectiveness of the human papillomavirus in reducing the incidence of cervical cancer in girls since the vaccine program started in the UK in 2008. That is huge. That means in 90% of people who have had the vaccine, they've not developed cervical cancer. Now, imagine if the people who are accepting the vaccine are mainly Caucasian. Begin to imagine what is then happening to the Asian communities and the Black communities because we refuse to take the vaccine. That means that although there's the government is talking about a great figure of 90% reduction, there are ethnic communities who may not be benefiting for whatever cultural reasons. We're not engaging with vaccination. So, this is another strong second message that I wanted to be aware of. I've shown you some of the pictures, but these are the cancers that I'm talking about. So when we say head and neck cancers, it covers a wide area. There are lots of cancers in the head and neck area. We're talking about your sinuses. And if there's something in the sinus, it will be a blocked nose or bleeding or a lump in the front of over the cheek. You'll be losing weight. If there's a cancer in the nasal cavity, it will be the same sort of symptoms. Cancers in the tongue, you will see a white patch or a red patch, or you see a raised little mushroom type thing. I will show you some pictures as we go along. When there's a cancer in the tonsil, you might see it when you look in the mirror and you say, oh, I think one tonsil is bigger than the other. It looks a little bit abnormal. In the voice box area, it will be a change in voice. And if the cancer gets big, the person begins to struggle to breathe or might begin to have noisy breathing. And they might notice a lump in their neck. A lump in the neck in an adult that's not going away for more than 3 weeks could be a number of things. It could be infection. You have a sore throat, tonsillitis, you get, your lymph nodes in your neck will swell up. It could be tuberculosis. There's someone coughing around, or you've traveled to the continent, you come back with a chronic cough not going away, you might have a lump in the neck. It could be a lymphoma. So lymphoma is a different kind of thing. It is a cancer as well, but they're cancers of the lymphatic system, almost the channels carrying clear fluid around the body called lymph. If you have a family history of lymphoma, your parents or any member of your family has lymphoma, it could be Hodgkin's or non-Hodgkin's and things like that. In my clinic, we see a lot of patients who come with a lump in the neck, and we take biopsies. We do the ultrasound and the biopsy at the same appointment. If it says lymphoma, we refer them to the lymphoma team. Then they get given chemotherapy through their veins to shrink the lumps down. If it's a cancer from the throat area, it will present with a lump in the neck. Now, lymph nodes, we all have lymph nodes in our neck, underneath the chin, underneath the jaw, in front of the neck. We've got lymph nodes underneath our armpits and our groin. Those are where, they drain those areas of the neck. When there's a problem, infections or something, they swell up. So when you have a lump in the neck, it could be that there is something going on in your mouth, in your tongue, in the throat, in the voice box area that's come out into the neck. It could be what we call a metastasis, i.e. cancer has moved into the lump in the neck. So please, if you have a lump in the neck or you notice someone with a lump in the neck that's not gone away, 3 weeks, they should please go see a GP. We can easily do an ultrasound and take a biopsy and know what is going on. So these are the areas that we talk about, head and neck cancers. It's a lot of cancers, salivary gland cancers, tongue cancers, gum, lip cancers. Any of these areas can give you symptoms. We've seen that there are some of these cancers that are on the increase. Thyroid cancer, for example, that is in part because we're doing a lot more ultrasound scans and biopsies, and we're picking them up. If you've got a family history of thyroid cancer, You may have a thyroid cancer, usually the medullary thyroid cancers. If you notice, the goiter is very common. That doesn't mean you have a cancer. It might be that you've got, low levels of iodine or, vitamin D and things like that in areas and dietary changes. But if you've got a lump in the thyroid, your voice has changed, you're losing weight, you've got neck lumps, go see your GP. Because it could be a thyroid cancer. I lead the thyroid cancer multidisciplinary team in Leicester, and we see patients quickly. We do an ultrasound and biopsy in clinic on the day patients present to us, and within a few weeks, we get them sorted, either with surgery or whatever treatment they require, like radiotherapy. I've said that there's an increasing incidence of cancers of the tonsil and back of tongue. That's the area we call the oropharynx, and it's preventable with a vaccine. So please make sure your children get the vaccine when they're in school. We're seeing some cancers declining, cancers of the voice box in particular, because it's closely associated with smoking. Smoking is what causes cancers of the voice box mainly, and a lot more people are smoking less. In the UK, in the last 30 years, we've seen a decline in smoking incidence. And as a consequence, we've seen a decline in cancers of the voice box, cancers of the lung. But we are seeing an increase of cancers of the side of the tongue, of the cheek area, of the throat area in the South Asian community. That is why I'm here this morning. That is the one message I'm here to talk about. That is what we're seeing because of the cultural pastime of chewing tobacco, chewing pan, chewing gutka, chewing betel quid. I know it's a cultural thing, and one of the incredible things I got to do was sit with Kirit and the South Asian Health Action Group. They said to me, this is common. It's just a social pastime. It's just what people do. There are lots of different things that can be put into pan. Different spices and lime and then some tobacco. I understand not all pan contains tobacco. This is what I want to learn from you and understand how we can take tobacco out of it. So tobacco smoking, tobacco chewing, alcohol consumption, excessive alcohol consumption, your genetics, your family, you may have a family history of any of these cancers. Some viruses cause cancer. So I've talked about human papillomavirus, which causes cancer of the tonsil and back of tongue. There's also Epstein-Barr virus, which causes cancer of the back of the nose, called nasopharyngeal cancer. So it's just something to be aware of. HPV sexually transmitted, so there's a lot of awareness around that. And this is what we would do when a patient comes to us in clinic. We ask all these questions about difficulty swallowing, pain on swallowing, change in voice, shortness of breath. We ask for a neck lump. When did it start? Is it painful? Are there lumps anywhere else? We want to know if you smoke or drink. We want to know if you got fevers, weight loss, night sweats that might be indicative of something like lymphoma or tuberculosis. We examine you. We have a look in the mouth. We feel the neck for any lumps. We put a camera up the nose, all in one clinic, and then we do an ultrasound at the same time and take a biopsy. Sometimes we have to do a CT scan or MRI scan or some special scans called PET-CT scans, where you get given radioactive sugar and it lights up red all over the body and wherever there is a problem. That's what we would do. Now, I will go back to the risk factors because this is the main issue here. So I've said, it's mainly tobacco smoking. So we encourage people to give up smoking cigarettes. There is help available on the NHS and with your GP. There's a lot of will. You need to be willing to want to stop smoking, but there is help available as well. There are smoking cessation teams in the GP surgery and in primary care that can help you, and in the hospital. And there are lots of different things that can be tried: nicotine patches, nicotine gums, lots of different approaches. And some people, they just decide to stop and they stop, but not everybody can do that. Now, excessive alcohol consumption, drinking high spirits and things, and constantly, tobacco and alcohol work synergistically to produce changes in the cells in any area in the mouth, all the way down to the throat and voice box areas. So those two combined are the two big risk factors. Now, we've talked about pan. And hopefully at the end, Kirit and Co can enlighten us a little bit more about this. But my understanding so far from engaging with SAHA and sitting down and listening to you is that, you know, there are lots of different types. It is a cultural thing. We sat down with the Bangladeshi community as well, and I was told, you know, sometimes even in weddings, you know, you can make your own pan and put whatever you want into it. But please, tobacco, lime and things like that, they really affect the cheek and the side of the tongue. So we need to do some work around that. It is awful what we're seeing. It is mainly the South Asian communities that have cancers in these areas, and they end up with big operations. We take half the tongue out, we reconstruct it with a flap from their wrists. They have radiotherapy. But if all we need to do is prevent it, I think it would have made a difference. I've talked about human papillomavirus as well, and that it's important that we take the vaccine. This is what the human papillomavirus looks like. It is a very common virus. There are over 200 types of human papillomavirus. A lot of it will cause just benign disease, warts. When we talk about warts, it's caused by the human papillomavirus. Warts can affect the throat area, they can affect the tonsils, they can affect the genital areas. But there are some of those viruses that are high risk. They are low risk HPV. So it doesn't mean you've got cancer if you've got human papillomavirus. But if you have a high risk human papillomavirus and it stays in the system and doesn't go away, persistence, it eventually leads to cancer. That's what we see in the cervix in women. And we see those changes in the early early changes in the cervix. And that's why the entire screening for women's cervical cancer has moved on from just pap smear, where we're just looking for abnormal smears, to looking for, is the human papillomavirus high-risk strain present? That's why the entire screening program has gone from just pap smear to, is there HPV DNA present? Because we know that once we find HPV that's persistent and high risk, it will cause a cancer, and then women get treated. And we're seeing the same thing in the tonsil and the tongue and the back of tongue. There's a vaccine available that will cover for warts and for cancers in the cervix, in the genital areas, and in the throat area. So I beg you, let's make sure that our children get these vaccines and they're protected. The human papillomavirus hides inside the cells. It digs inside the tonsils on the cervix. The tonsils are like, they're valleys and hills. So it just goes into the valley, hides there. It hijacks the DNA of your cells, because your cells are constantly reproducing, and it reproduces itself. That's how it causes cancers. Now, I've talked about HPV. There's a vaccine to prevent it, so we should talk about that at the end as well, and how we can engage with this as a community. The high-risk HPVs we need to keep an eye on and be aware of. These are sexually transmitted, so we need to think about sexual habits and cultures, and think about how we prevent these. Many infections will go away on their own. So your immune system, we're all going to catch HPV at one point or the other in our lifetime. It's a ubiquitous virus. It's present everywhere. But your immune system will get rid of it. The difference is that some people's immune system does not get rid of it. It stays in the system, and then it begins to cause cancer later on. But it's difficult to know whose immune system might not get rid of it, and that's why a vaccine is important. So signs and symptoms of the cancers. I've already talked a lot about this, so this is like a summary. So the key here is, if it's persistent, more back to Rena's question about just having a difficulty swallowing. Yes, we'll all get that from time to time, but if it persists for more than 3 weeks, there is something called a 2-week wait pathway, which is an urgent pathway to rule out a cancer. It exists for all the cancer types, for head and neck, for breast, for lung, for colon. If you've got any symptoms that you're worried about that hasn't gone away, your GP is obliged to refer you to hospital to be seen within 2 weeks. Okay, so for head and neck, if you've got any of these symptoms lasting 3 weeks or more, I think there's a conversation that has to be had about how we engage with our GPs. We shouldn't pull back. We should speak up when we go to the GPs. Let's not be afraid to say exactly, the symptoms that we're having. Let's not think that anyone's going to think anything of us. Let's just go to the GPs and say, I have noticed a lump in my neck. This lump has been there for 3 weeks. It has not gone away. I am concerned it could be something serious. I know there is an urgent cancer pathway. Could you please refer me to the hospital? They will refer you every single time. I am struggling to swallow. I have a pain when I swallow. It's on this side of my throat. It hasn't gone away for more than 3 weeks. I am aware that you should be referring me to the hospital. Can I have a referral, please? Sometimes I think it's when we're engaging with primary care and we're not quite sure what to say or how to say it, that we downplay our symptoms. Oh, it's just a little sore throat I've had. Don't worry about that. I'll just take paracetamol. Please, let's pay attention. So a lump in the neck, difficulty swallowing, pain on swallowing, change in voice, shortness of breath, weight loss. And for some of the cancers in the sinuses, your nose might be blocked, you might get nosebleeds, you might see a lump in front of the face. For early cancers in the tongue area, it might just be a whitish patch you notice on the tongue, on the side of the tongue. So if you've got any of these symptoms, this was produced by the Oracle Cancer Trust, just like a quick summary for the public to be aware of. Persistent hoarse voice, difficulty swallowing, white and red patches, and I'll show you some pictures of those. Lump in the neck, painful throat, a blocked nose. I will keep repeating this so that it sinks and you will remember this at the end of the talk. These are the symptoms and things that we're looking for. Right, so here are some of the pictures. I'm going to make this a bit real now. So I'm going to be showing you some pictures of actual cancers now. So you will see the first one is a whitish patch. This is what you're looking for on the tongue. If you notice a change like this, we call this leukoplakia. It means a whitish patch. It is a pre-malignancy. It is not yet a cancer, but it is abnormal and it could turn to a cancer. Okay, so what we tend to do when we see this is we take a biopsy. We have a feel of it, we do some scans. My colleagues in maxillofacial surgery, I've got some incredible colleagues, Mr. Mayor, Raj, Phil Amirali and co. They'll take a biopsy of that area, and if necessary, they'll remove it under local anesthetic and they can take it out. So whitish patch, it doesn't have to be white, it could be red. It could be a reddish patch. If you look in the tongue in the mirror, stick your tongue out side to side. If you notice anything, or ask someone to have a look, if you notice a whitish, reddish patch, sometimes it's fungal infection, yes, but a patch not going away 3 weeks, please go see your GP or your dentist. Your dentist might pick any of these up and refer you as well, by the way. If you notice a lump that is raised on your tongue, it could be a cancer. So the middle picture there is a tongue cancer. That's how it looks on the side of the tongue. And it can be due to chewing pan or chewing tobacco or smoking or whatever it is. But we see a raised patch. We will take a biopsy. We will scan everywhere else in the body to make sure it hasn't spread. And the way we treat that is the maxillofacial team will take it out with a margin. If it's a big area, we can reconstruct the tongue by taking a flap from the wrist. We'll take flap of skin from the wrist and we plumb it in there and it heals quite nicely. But that is a tongue cancer if you've noticed that, or you notice a relative that has that. And the final picture shows you, a lump, like a hard lump with like a necrotic core, a breakdown in the middle, in the hard palate, in the roof of the mouth. So when you look in your mouth, look in the roof, look at the tongue, look at the sides of the tongue. If there is anything like that in the roof of the mouth, please go see your GP. Your dentist might pick it up. That's a cancer in the hard palate. Now, surgery can remove that, and we can reconstruct it with bone from elsewhere, or you can have radiotherapy, but that's a cancer. I'll show you some other cancers in the tonsil now. So this is the back of the tongue. When you stick the tongue out, right out all the way, you might see a little lump or a swelling right at the back of the tongue. That's a tongue cancer that we've treated. We see it a lot better on an MRI scan. So we get scans that show the size of the lump, and we can take it all out and remove it with surgery or give radiotherapy. I'll show you some cancers of the tonsil. So this is what a tonsil cancer looks like. I had shown normal tonsil at the start. So you can now see that those little oranges at the back of the tongue on one side is really big. if you notice your tonsil is bigger on one side than the other, it could be a lymphoma, it could be a cancer of the tonsil. In this case, it is a cancer of the tonsil. This patient will present with pain on swallowing, difficulty swallowing, lump in the neck, pain in the left ear, more than 3 weeks. And then we had a look in clinic, and this is what we saw. So that's a tonsil cancer. Now, there are scans that we use, MRI scans, PET CT scans. And this is a PET CT scan. It lights up red. Cancer cells are rapidly dividing cells. They take up sugar to divide. So we lace the sugar with radioactive material. So we use it to identify where the cancer is, and we use it to follow patients up after they've had treatment. So in the top scans, you will see the MRI and PET CTs lighting up with the arrow on the left side. That's where the tonsil cancer was. And you see that there's a lower glow, and there's another sort of satellite redness in the neck. That's the neck lump. That means the cancer in the tonsil has gone into the neck. And those pictures at the top are before we treated the patient. The pictures after, you can see the redness has gone down. So the patient has responded. So that's how we use these scans to say, have you responded, yes or no? The redness disappears. A lump in the neck. This is one of the strongest symptoms to look out for. A lump in the neck in an adult is a cancer until proven otherwise, particularly if it's been there for more than 3 weeks. So please do not dismiss, men, when you're shaving and you notice a lump somewhere, don't dismiss it. Wives, when you notice there's a lump in your husband's or even in yourself, make sure they go see the GP. The reason why I'm saying this is what we're seeing with the human papillomavirus is that patients, apart from having a lump in their neck, they may not have any other symptoms. They may not have a sore throat or difficulty swallowing. Their voice will be normal. They don't smoke, they don't drink, and all we see is a lump in the neck. This is what the human papillomavirus is causing, and we call this an unknown primary. We can't find the primary even when we look with our camera, and all we see is a lump in the neck. So please be aware that the virus is causing cancers and lumps in the neck in people who don't smoke or drink and who don't have any symptoms. So let's just be aware. This is one of the strongest symptoms to look out for, a neck lump. Now, cancers in the sinuses. I showed you your normal sinuses at the start. This is a sort of the cheekbone sinuses. You could see it's completely destroyed. That cheekbone is gone into the eye on the right side. This is a cancer that's presented with a blocked nose, bleeding from the nose, losing weight, change in vision. We can put a camera up the nose, so you could see, we could do endoscopic sinus surgery where a camera goes up the nose and we can take the tumor out, or we can offer the patient radiotherapy, chemo, and some reconstruction. Cancers at the back of the nose. The eustachian tube is where the ears open to the back of the nose. So when we look with a camera, this is what we see when there's a cancer there. And then when we scan, so the sort of patient would have therapy and chemo to completely and those operations can take 12 hours. I would do that and remove it. Yeah, so cancers in the top end of the swallowing pipe as well, behind the voice box, hypopharynx. I'll take these pictures off now. So the point is, there are early cancers, and there are things for us to look out for that we can pick up very easily. A lump in the neck, a white or red patch in the tongue, a tonsil that is bigger, change in voice and things like that. If patients present early, for example, the voice box cancer I showed you, radiotherapy will give you a 96% survival for early voice box cancer, 96%. We can do laser surgery, and it's about 94%. But the moment it goes into the voice box, into the Adam's apple cage, the whole thing has to come out, and that's a 12-hour surgery, and there isn't guarantee that it hasn't spread. So it's important that we turn up early. So in terms of treatment, when patients present and we say they've got a cancer, they can have radiotherapy or chemotherapy. These are standard treatments. Radiotherapy for any of our head and neck cancers tend to last about 6 weeks usually. So Monday to Friday, apart from Saturday and Sunday, they blast the area with radiotherapy to destroy the DNA and shrink it down. And then patients get given chemotherapy, which is drugs through the veins, at the start of each week. So you get, if you're able to, if you're under 70 and you don't have any problems with your heart and lungs and things like that, you get given chemotherapy and radiotherapy, but it does cause side effects, difficulty swallowing, breathing problems because of the swelling. It can cause tiredness, dry mouth, no saliva, skin changes, problems with hearing, ringing noises. Every patient has to have some of their tooth taken out if it's carious or very dodgy teeth. They have to have a feeding tube put into their stomach. Their throat can narrow up with strictures. So you can see all the problems that can happen when you have radiotherapy and chemo. So it's best to avoid it if we can pick it up early. So even though there is treatment, the side effects of treatment is not easy on the patient. So why not prevent it? Why not pick it up early? It's better than cure. We can operate on, so there are lots of things that I and my colleagues would do when we see a cancer in the throat or in the mouth. We could use laser, we could use the endoscope, we could use the robots, and all of that is available in UHL. But the benefits are for early stage cancers. T1, T2 is what we call them, very early stage cancers. It reduces the length of stay, the speech and swallowing is better, and you avoid all the side effects of radiotherapy or splitting the jaw. This is me doing robotic surgery in Australia, in Adelaide. The camera goes into the patient's mouth. It magnifies what I see by about 10 times. And I can see the cancer clearly, and I can see where I need to take a margin. It's great benefit to the patient. This treatment is available in UHL, in your hospital here in Leicester. And we started the program 18 months ago, and it's doing really well. We've operated on about 80 patients. But all those patients are early stage cancers. I wouldn't operate on a late stage cancer because it's gone too far. But treatments are available. And this is us in UHL. This is the equipment you have here in your local hospital. The equipment for the surgeon to look at the cancers and magnify it. Robotics is available for prostate cancer, for colon cancer, for head neck cancers, gynae cancers in UHL. But the critical thing is not so much about the treatments we have, but preventing them and helping us to raise awareness so people don't even need them in the first place. But this is us in the robotics thing. It's really good for seeing the cancers well. It magnifies what we see. It completes the resections. The quality of life is better, and it avoids chemoradiation for my patients when I can operate on them. And this is myself and my team, Mr. Peter Comboy, Mr. Manish Mayer. He's a maxillofacial. He works in the maxillofacial team. They deal with the cancers of the tongue and throat area and jaw and jaw area, and they do a lot of incredible surgery. Mr. Comboy is a very supportive senior surgeon, and we work together. And this is all the sort of setup for robotics. That was the first case that we did in Leicester, and the patient is doing incredibly well, and that was 18 months ago. And so there are treatments and there are benefits to robotic surgery. There's chemoradiotherapy, there's better pain control, better speech, you avoid toxicity, the patients do well. But these are patients who have presented early. This is the point. The point I'm making is if patients don't present on time, they can't have any of these fancy treatments. We will just say we can't treat this. So please, it's important that we raise awareness, and this is surgery that we do, and the robot arms go into the throat, and we can completely take the cancer resection out. This is laser. Laser is also available. This is before we had the robots in Leicester, and you could fire a laser to cut out the throat cancer. The cameras go into the mouth as well for endoscopic surgery, and we used to do this in Leicester as well. There are lots of different types of robots that have been used. I've used the Flex robot in Adelaide as well. It's a different sort of construct. It's flexible and it glides into the back of the tongue and goes all the way towards the sort of voice box area, and you could see how it works. And this is us sat in Adelaide with the flexible robots as well, and Prof. Suren Krishnan, who is a top robotic surgeon in Adelaide. There's a Cambridge robot as well. So I'm showing you that there are lots. Technology is moving, is what I'm trying to say, and there are better treatments, but they work for people who present early. Okay, anyone who presents late can't get any of this. I'm just going to calm the presentation now with a nice picture of Kangaroo Island in Australia, because I had fun apart from just operating as well with my family. I'll just quickly mention thyroid, because I know it's a very common thing, particularly in our Asian and African communities. Dietary things, iodine deficiencies. That's why the government puts iodine in your salt to reduce this. Vitamin D deficiency is very common. You might notice a swelling in the neck. It might cause difficulty swallowing or breathing. We would have a look. We'll take a family history. We stick a needle in to take a biopsy. We could do CT scans if necessary. And we can do surgery or radioiodine. But again, you need to present early. This is the sort of scans that you might see wrapping around the windpipe, and we can take half of it out or the thyroid gland out. And I do thyroid surgery as well in UHL, but the patients who benefit are the ones who've come early. That's the point I'm making. And we could do an ultrasound scan and a needle test on the day that patient see us in clinic, or we could do surgery, and we're very careful of the nerves. I'm going to talk a bit about prevention. HPV vaccine. Okay, very, very simple preventive measure. Please make sure your children age 12, 13, boy or girl, gets given the HPV vaccine. It is safe. It has been shown to be effective. It's reduced cervical cancers by about 90% since 2008. But who is benefiting from it? The people who have allowed their children to be given the vaccine. So it is possible we might see a divergence in outcomes in our communities if we don't engage with vaccination. It will cover a lot of the HPV strains, genital cancers, head and neck cancers, cervical cancers, the ones that cause cancers. I've said this in children. There are some high risk group those men under 45 years who have sex with men, particularly in America and places like that. People who are high risk, who are immune compromised, HIV immune compromised patients can also be given the vaccine. There are different companies available, Gardasil, Severix, but they contain the number of viruses they protect against varies. Some will cover 5, some will cover 9. There are lots of different vaccines out there. Now, in closing, there are further resources that we can look at. You can have a look at these videos on HPV, but there's also the Sign Away Cancer campaign that I've been involved in with the Oracle Head and Neck Trust. This is a video that we made last year with Tamara Khan and the team, talking about, giving people, making sure your children, you sign when they send that thing from school to say that, yes, I'm happy for my child to have the vaccine. Like I said, I don't work in isolation. I work as part of a fantastic team, and we've got nurses, we've got oncologists, we've got our speech therapists, dietitians. They look after our cancer patients really well, and we help our patients through the journey. In our communities, cancer should not be a stigma, and let's support people who have cancers. Let's surround them with help. But we are there in the hospitals, but it will be great to increase engagement as well. We've got fantastic, members of staff in our clinics, in our theaters. A lot of them are also from your communities in the South Asian community, Mr. Tanwer, Kirit, Maria, everybody, and we look after all our patients. We got our Macmillan nurses. So when a patient has a cancer, please be aware that they are supported. Every patient has a Macmillan specialist nurse that they can contact. Let's not say, I don't know who to talk to, I couldn't contact the hospital. You should have a Macmillan specialist nurse number that you can say, my relative is struggling, I need help, can someone see us please, there's a lot of pain or something. So Macmillan services, they're fantastic, but please let's make sure we utilize those services. I'm just going to show Kirit and co what we've done with the work that we've done with SAHA. Now, this is specific to your group, because last year we sat down and we talked about, head and neck cancers and the disparities that we're seeing. And Tamara and myself, we presented this in national conferences about what you told us and what we're working for. I've talked about the increasing incidence, as you know. I've said, we should do the HPV vaccine and that people who come late are worse. And we've talked about So when COVID hit, we already had inequalities before COVID, i.e., some communities were doing better than others when they had cancers. The South Asian, the Black communities were doing worse. Since COVID, that divide has widened, unfortunately, because we told people to stay at home. There was lockdown. So by the time people came out after COVID, they came to us with big lumps in their throat and in their neck. So let's be aware that COVID has widened the inequalities, and it's important we talk about, the risk factors: tobacco, pan, betel quid, oral hygiene, and where the pathways are. We had to do something about it, and this is where, working with Kirit and Co. This is what you told us. We sat with lots of different groups: Punjabi, the South Asian, Bangladeshi, Eastern European. We sat with lots of groups last year, including SAHA, and I had a wonderful evening and several evenings with Dr. Giannina Postavaru, Alex, and Kirit was present for those things. And you poured out your community and said, look, we can help you. You can come to our temples. We can organize things together. You talked about. It was beautiful. So what we want to do, and these are the pictures from our engagement. So I really want to say thank you to Kirit and Saha for engaging with us. This was beautiful to see. People really talk to us about how we could engage your community, and we want to do that. Kirit and Co said that you can use videos to communicate with your community, and you've done that before for some other projects, and we're hoping to work with you to produce videos that talk about head and neck cancer symptoms and risk factors in your language, with your communities, the ones speaking into those videos, not just someone random from elsewhere. That's what we want to do with Kirit and Co and SAHA. And we were with the Bangladeshi group as well. We sat with the women and the men. So this is us engaging with you, and we want to continue to work with you. We did the same things with the Black community in Highfields. And since then, we've worked with them. We've done a drama show talking about head and neck cancers, and Kirit very kindly attended as well. From that event, we decided we were going to do, this is what we learned. We were going to do wider cancer conversations, which fits well with what SAHA is trying to do. So we're not just going to be talking about head and neck cancers. We now want to talk to you about breast cancer, colon cancer, lung cancer, and all the cancers that affect our communities disproportionately. And this is where Dr. Ayodele, I'm very grateful to her for starting to talk about breast cancers. And she works with your cancer connectors as well. So we'll be coming to you with cancer conversations around breast cancer, colon, lung cancers in future. But these were the key things that we learned, that, we can raise awareness, and there's a cultural stigma in our communities, and taboos around cancer that we need to address in a culturally sensitive way, that there are trusted key messengers like Kirit and Co and SAHA in your communities we need to work with. We need to continue to engage. We need support systems for patients who've had cancers in the hospital, from diagnosis through to treatment. And we want to collaborate for research. Let us take part in research. If we don't engage in research, the data, the outcome of those research then doesn't benefit us, because they come up with a drug that doesn't work for us. So it's important that we engage. And this is all that we did. Kirit, that's you there. We went to EVA FM. We started talking about this on the radio. We did lots of events, cancer services. I'm always in the community. I'm willing to come to you and talk about various things. We've had lots and lots of awareness events, and I'm grateful to Kirit and Co and EVA FM for hosting us. We had the BBC come along to talk about the screening. Kirit will remember this because Saha came to the head and neck screening in the Highfields Rangers. If you remember, we were just screening people, and it was great. Saha, you have been the most organized, cohesive group that I've been working with, and it's beautiful to see. People came out, the South Asian group came out, we checked people over, the BBC talked about it, working with my colleagues from Derby, Bindi, Dr. Marsh. The middle bit is the HPV vaccine video that we've made, so please go have a look at that. And what we plan ahead in terms of Oracle across the country. So Oracle's work is not just in Leicester, it's in Tower Hamlets in London, working with the Bangladeshi group, it's with Newcastle group, understanding lots of different things. But what I would like to do with SAHA is to do those videos, complete those awareness videos with SAHA, saying out what the symptoms are and what people should do. And I think if we can do that and engage in the wider cancer conversations, I think it'll be a brilliant thing. I'm going to close. So I've said that head and neck cancers are varied. I've said that, you need to pay attention to neck lumps. It could be a cancer. Smoking alcohol, chewing pan, chewing betel quid, human papillomavirus are the main risk factors. It will depend on, the symptoms will depend on where it is: breathing, swallowing problems, neck lumps. Treatments can be surgery, radiotherapy, chemo, or immunotherapy, but early diagnosis is crucial. When you come early, you have the best treatments, including robotics. When you come late, it will be either just pain control, best supportive care, or treatments that won't cure you. So thank you so much for your time. And these are my contact details. I'm happy to be contacted. I'm on social media as well, on formerly Twitter, X. I follow SAHA on all these platforms, LinkedIn, and on Instagram. And I think, we can do a lot of work together. So it's been a real privilege. So thank you so much for your attention.
Thank you, Dr. Dejo. That was very, very informative. It covered a lot of the things that we wanted to discuss today, especially around the symptoms. Some of the key messages you gave out about early detection, obviously, that's one of the key reasons why we won. And the whole session was based around symptoms. Obviously, with all the different types of cancers, you've covered just a few, and especially around the head and neck area, but with all the other different cancers that we've mentioned and that are, that exist. What we want to do, part of this project as well, is recruiting community connectors. That's one of the main parts of this project. And each one of those connectors, what we're hoping to do is give them a specialist field. So we'll be connecting them with people like yourselves, consultants, specialists, who can give them that extra information. So when they are speaking to someone, they can provide the correct information, assist them with any support, show them, signpost them where to get help. But I think one of the key things there is obviously, as you said, where possible, we want to try and prevent it. And if that's not possible, we want to detect it as soon as possible. So I think Kiri obviously mentioned in the messages, we've had quite a few questions for you. So I'll go through them with you now as well. Kirit mentioned, obviously, we've got a separate project to this as well, which is focusing solely around oral cancer, mouth cancer. So some of the products that you described, the bans, the other various things that people take with tobacco, alcohol, etc. These are things that we will be focusing on. And again, your assistance and support will be very grateful. Again, just want to thank you all. From us and the whole team at SAHA and everyone listening, because there was some really useful information. I'll just go to some of the questions. So we'll try and give you some quick fire questions here. I know you've given quite a presentation, so let's...
Well, Kevin, while you're looking, there was a couple of questions on vape. So is vape dangerous? And also with the younger people, what work can be done with young people to raise awareness?
Thank you so much, Kirit, and the person who's asked that question. So vaping, we don't know enough about vaping yet, is the honest answer. What we know about vaping is that it contains less of the toxic chemicals and materials that cause cancers, the nicotine that we were talking about in tobacco. It contains less of it. So you would think that therefore the risk is less. But we don't know that because we don't have longitudinal studies yet that have followed people for years to say this person has vaped for the last 10, 20 years. Did they have a cancer? Yes or no? Don't forget that the evidence for tobacco causing, cancers came from a longitudinal study. They actually, in the Dole study, they followed up doctors. In those days, it was trendy and expensive. So it was doctors who were smoking. And they followed this group of doctors cohort for several years, like 50 years. And then they found that those who smoked were developing lung cancer. That's how we know for sure that it's tobacco. So we don't have longitudinal studies for vaping yet. We know it contains less nicotine, and therefore, some authorities feel it will be safer. The problem with vaping, though, is that the companies are targeting our young people. There is a lot of that sort of marketing towards young people, and in America, there's been a lot of regulation around that, because we're not completely sure about its safety, and there's some bans coming in. So I think with public health, there's going to be a lot of working with public health, looking at vaping. We don't have longitudinal data yet. We know that some smokers find it easier to come off smoking by going to vaping first and then coming off. But we don't want our young people now taking up vaping, and for an outcome we're not sure of. So that's vaping. Is there work to be done with young people? Yes, we need to raise awareness around the causes of all cancers, and tobacco, to avoid tobacco and excessive alcohol consumption, to be vaccinated. For any of these cancers that have vaccines available, they should take it. Human papillomavirus vaccine is available, and our young people should take it. And they need to be aware that these things, some of them are sexually transmitted, and they need to be aware that they should pay attention and not engage in extreme sexual practices. So I think those are the things to sort of talk to our young people about.
Just a quick question, sorry, on the HPV vaccination. Once the child has passed that age, can they still get it? And if so, how would they get it? That's one of the questions as well.
Yeah, so the HPV vaccine can be given, certainly in America, even up to when you're 45. But we know that we're dealing with the NHS, and we don't, money is an issue. And therefore, it's given to people who will benefit the most from it. Even if you're past the age, you can always get the HPV vaccine privately if you're willing to pay for it. But the reason why the vaccine is given when people are age 12, 13 is because they have not become sexually active. That is why it's at that age, before they're exposed to the high-risk strains of human papillomavirus that come when people become sexually active. They get given a tiny bit of, there's an area of the virus called the L1, which is a capsid protein. They engineer that, they expose your immune system to it, your immune system reacts to it, so that when you then come across the real thing, your body says, I've seen this before, I'm going to get rid of it. That's how vaccines work. So they give the kids just a tiny bit of it so the immune system can recognize it in future, before they come in contact with the virus. Now, although vaccines work after people have already become sexually active and contacted the virus, it doesn't work as effectively because your body doesn't react as rigorously. We call that seroreactivity. You don't mount up such an immune response. I don't want to get too technical, but yes, it can be gotten up until the age of 45. If anyone is in a high-risk group, they've got HIV, they're immune compromised, they're on some medication that compromise their immune system, they've got transplants or whatever it is, yes, you can have the vaccine. On the NHS, you may need to go pay for it if you're not within that age group. I think they've got the whole system is moving to either a once or single dose now from what it was before. But you can certainly get the vaccine up until age 45.
Thank you. Go on, Kevin. Thank you.
Thank you. We've had another question. Is a permanent blocked nose and a nasally voice needing nasal spray daily at night, is that a potential problem?
Thank you for that, Shashi. So a permanent blocked nose and nasal voice may be a number of different things. It doesn't mean that it is a cancer at all. That's a very common symptom. We all have a blocked nose. You all catch a cough and cold and something. It could be a sinusitis, just inflammation. Lots of people have hay fever, which means, when, pollen or allergens fall on your nose, your body reacts to it, you get swelling and you get discharge from your nose. That's a very common problem. Nasal douching, like sort of salty water, washing out those allergens, using a steroid spray, Beconase, Flixonase, Avamys sprays, they help to shrink down the nasal lining so you can breathe better. But if you're having lots of other things with it, constant nosebleed, blocked nose, swelling on the face, it's best to get checked out, because the GP, will refer you in, will have a look with the camera. And in some patients, they may have a polyp. It may be that you've got a polyp up your nose from constant inflammation. And polyps respond to steroids. So steroids shrink down polyps, either in tablet form or in spray. And if you need surgery, you can have endoscopic sinus surgery, which is a camera up the nose to remove the polyp or biopsies or take things out. But before we do all that, we'll get a CT scan of your sinuses to see what's going on. So if you've got a persistent problem and it's not going away, go see the GP, and I'm sure, you know, on referrals, we can assess you. But it does not mean that you have a cancer. That's a very common thing.
Thank you. Also, we had a couple of questions around chewing gum, chewing betel, and also acacia nut, areca nut, I believe
Yes.
it's pronounced. What would you say around chewing gum, chewing betel, or areca nut?
So those are risk factors for cancers of the tongue, and particularly the side of the tongue or inside the cheek. That's just what we're seeing. And I know that, you know, people enjoy chewing these things and it's a social pastime. But what we would like to do with Kirit and SAHA is work with us to understand the culture around it, to understand which bits of what goes into pan is the one that causes cancer. We don't want to throw the baby out with the bathwater. Can we take out the tobacco bit or the bit that causes cancer from it, and people can still enjoy what they enjoy? But that's not information I have, and I think this is where SAHA comes in for us to work together to try and work around the messaging. So the messaging is that, you know, we are seeing cancers in people who chew pan. It causes a lot of fibrosis and cancers in their cheek and tongue. What bit of the pan is causing the cancer? Is it the lime? Is it the tobacco? What is it? Can we take it out in a culturally sensitive way? We don't want to come here and go, stop chewing pan or stop. I don't know. We can't say that. We just want to work with you. So yes, it's a risk factor, and it's a recognized risk factor. Gutka, areca nuts, pan. We know that they cause cancer. It's just we need to work with you to get the right message out and work with the people who sell it, who might not know is causing cancer to your community, and work with you to see are there things we can take out that will make it safer.
Thank you. We've had one question come in privately, so I'll just read that out. There's someone who's had a kidney transplant having immunosuppress. Can they take HPV at the age of 68?
Well, yes is the straightforward answer to that, but because when your immune system is compromised by drugs, you know, you've had a transplant or something, or you're on immunotherapy, it means you're susceptible to infections, and you can. There are some cancers as well that you might be susceptible to. At 68, the effectiveness of the HPV vaccine, like I said, will be low compared to if we were giving it to a child who was age 12, 13, who had not become sexually active. So I think the risk is lower in that age group, and therefore may not be particularly beneficial. Is my reading of it. If I think in that age group, it will be more important to identify any symptoms that might be problematic, to be assessed and to be treated. Patients who are on immune suppressants are closely monitored anyway, and if you notice anything unusual. But I think in that age group with immune compromise is more about preventing, you know, respiratory infections, flu, and things like that. I don't know that at almost 70, it will add much more benefit.
Thank you. We've also got someone with a hand up. We've also got another guest speaker we need to get to.
Okay.
So, Dr. Dejo, you are with us for a little while until the end of the session, right?
Oh, yes.
Okay, brilliant. So what we'll do, we'll come back to some of them questions. The person with the hand up, we will get to you shortly. We've got one quick guest speaker. Her name's Kamini. I'll just see if she's still online, if she can unmute herself.
Hi.
Hi, Kamini. How are you?
All right. Good afternoon, everybody.
good afternoon. Most people are on mute, but I'm sure they send you a good afternoon. Obviously, one of the questions that we wanted to ask you around today's theme and recognizing symptoms, we just wanted to ask, what was it like for you in your experience finding those symptoms, and how did you go about dealing with that?
Okay, the first thing that I found was a lump in my breast in the shower. It was there for about 3 days. Apart from that, apart from feeling a little tired because I was in a new job, there was nothing unusual, nothing different to my life previously. So there was nothing, and it was just the lump. So I decided to go to the doctor. And it was the doctor referred me to the breast clinic, and it was confirmed that I did have cancer.
Okay. Obviously, it's very sorry to hear that. Going through that as an experience, it's never easy. From finding the symptom to receiving treatment, how long was that process for you?
The doctor's appointment, it was about 2 weeks away, but once I went to the doctors and they realized that maybe it needed to be seen, I was referred to the breast clinic, who basically sent an appointment almost straight away. Once I was there, they did the biopsies, and that's when I realized that there was something wrong, because they did more than one biopsy. They did quite a few, and then they said I had to relax and I couldn't drive and everything. So that's when I realized something is wrong. Then I had an appointment with the consultant a few days after the biopsy, and it was confirmed there that I had a very aggressive cancer, the HERS2, and the consultant suggested that, if I was happy with it, if this was a Thursday evening, they could fit me in on Monday morning to do the surgery, or if I needed time to think, I could have another 2 weeks. But he did suggest that I shouldn't leave it very long because the cancer was extremely aggressive. So really on the spot, me and my husband decided that we'd have the surgery the Monday morning. And the Glenfield Hospital were excellent. Everything, happened systematically, very quickly, and it was very short time for us to sort of take all this information in and everything, because I'd never been near anybody who'd had cancer personally. So I'd not seen how chemotherapy worked, how everything worked. We'd heard of it, but not seen it personally. But the consultant who operated on me was excellent. Even after the surgery, he came to me, he told me what had happened, how, what they'd taken out and how everything was, and I would be able to go home the next day since my blood pressure was low. And then from after the stitches were taken out, I had a lot of help from them. I didn't find Macmillan very helpful because I wasn't allocated a Macmillan nurse. And the stays at the hospital were difficult because the night shift staff were sometimes very noisy or that, and you couldn't get rest, or they didn't answer your questions. If they said you needed injections and you asked, well, what is this injection for? They weren't forthcoming or explaining things. Whereas the consultants, the surgeons, they were excellent. I had no issues. But on the other hand, people like Lauros Together Against Cancer, they were very helpful as well, because they helped me through the process. And then we also opened our own group for Asian women, which was the Belgrave and Rashid Cancer Support Group, because we found that there was nowhere for Asian women to go.
Okay. Obviously, varied experience there in how people react to your treatment, or obviously the support they give you. For someone going through an experience like that, or someone who may have found a lump, or someone in their family, what would you explain to them about dealing with the symptoms? Would you say it's definitely better to seek that medical advice straight away, or should they be taking time, speaking to family, find out what they need to do?
Honestly, the facilities in this country are so good. They send you packs through your door for your bowel cancer. The women get to get their smear test done. They send you the appointments. Keep to those. Go for them. you know, at least it puts your mind at rest. And just now we've had the presentation from the consultant at UHL. And again, he said, if we find it early, you know, the chances are much, much better. So why not take advantage of that? Go for your appointments. They're keeping, you know, they're making the effort for us. So we have to make the effort from our side as well. And I don't know why people are scared to go for them. You know,
Yeah.
you go to your dentist, you go to your hairdresser, you go to the barber, and this is same. Go for your appointment. You go for your blood test for your, you know, iron or vitamin D or whatever, and this is the same thing. Just go for your appointment. It's only 5 minutes, 10 minutes, but it'll save you a lot of pain and a lot of pain and everything else later on.
Yeah. I think Dr. Dejo was very clear in explaining how the survival rate, you know, decreases significantly the longer you leave it. So thank you for that. And just, you know, echoing that message for us. And finally, we just want to quickly ask you, groups like ourselves, you know, you mentioned support groups, etc. The consultants, the specialists, the medical staff, all of them are brilliant in their own way, but there's only limited time that they can afford to patients, obviously. People do need that extra support sometimes outside of the medical staff. Groups like this, connectors in the area, people who are aware of symptoms, how to help people, people who understand culturally sensitive material. Do you think that more groups like this are needed in the community?
Absolutely, because you know, people can, if from my own experience, because I've always spoken about cancer, I've not hidden it, because you know, people used to walk away from me when they found out I had cancer, and
Yeah.
I would say to them, well, why have you walked away? It's not catchy. You're not going to catch it from me, and I'm still the same person, although I'm going through the treatment. I've not changed in any way. And you know, then once they know that you can talk about it, they'll come to you and ask you questions and that. And it you know, it helps them as well. And because cancer, you could have had diabetes, you could have had something else, so you know, kidney problems, and cancer is the same thing. It is an illness and there is treatment available. So we need to
Yeah.
speak about it, we need to talk about it, and we need to get together and deal with it. And again, like the doctor just said, you know, the sooner it's found, the better treatment you'll have.
Yeah. And I think, again, like you said, we are very lucky to be in Leicester, Royal Infirmary,
Absolutely.
Glenfield General, the medical stuff we've got here and the expertise that we've got at, you know, just literally on our doorstep. It's absolutely amazing. So
Yes.
thank you to all medical staff in Leicester while we're there.
Yes,
Thank you,
thank
Camille,
you.
for sharing your experience as well. You will be joining us in future sessions because we've got different themes coming along. So thank you for
Thank you.
today. Really appreciate you sharing that. And if there is anyone listening, if anyone has any symptoms, anything they feel like they need support with, please do drop a message. You can contact us at connectors@sahauk.org. And in the message, we've also left our work contact number as well, so you can contact us on there as well. I'm just going to go back. I think we had another question for Dr. Dejo. I'm just having a quick look. Okay, that was regarding... Sorry, yeah, go on, Kiri.
We had a hand raised from Magalan. Sorry if I pronounced your name wrong.
Sir.
But do you want to ask your question?
That was... let me just check.
Hi. Yes.
Hello.
What I would like to know is, how can we support someone who has just been told their nasal polyp is cancer? What information should we share or avoid?
Okay, so we'll go to Dr. Dejo first, I think. We can let you know about other support that is available. But please, Dr. Dejo.
Thank you so much, Mangalan, for that question. I think it's a very important question which speaks to the core of a cancer diagnosis. A cancer diagnosis is not just, doesn't just affect the one person with cancer, it affects their family, their children, their spouses. It affects their work, it affects their self-esteem, it affects, you know, their hope for the future.
Yes.
It affects grandkids. So, you know, it is a very delicate time. We are very careful, and we do this sensitively in hospital. When I speak to my patients, I have my Macmillan nurses with me. We encourage them to come to the appointment with their partner or their children, because when you tell someone they have a cancer, they might not fully take in the information in that moment. They get overwhelmed because, you know, they're worried that, does this mean I'm going to die, or I'm not going to be here? How long do I have? Am I going to be able to go back to my family or my work? So there's so many anxieties and worries in that moment that we encourage people to come with at least another member of their family, so that they can listen and ask us the questions, write down any questions that they forgot to ask at the appointment. We always give them contact details of our Macmillan nurses or our team to say, you know, if you've got any further questions, please contact us so we can answer these. We still bring them into further appointments in hospital with our allied health team, with our oncologist and myself. So it's a really challenging time. We try to be as honest with patients as possible, because there's no point giving false hope. In my work, if something is advanced, I say so. If we think we can cure it, we are very clear about what we're trying to do to cure it, or how we're supporting them, even if we're not curing it. Because there's so much about supporting them to treatment, pain control, anxiety, appointments, where do they go, you know, who can they talk to? So it's not just the hospital that support patients with cancers, it's also yourselves, the communities, the families. As long as we understand that cancer is not a death sentence, when you hear that someone's got a cancer, please support them. Please give them a phone call. Please go visit them. Please sit with them in silence, because they may not even have the words to express how they're feeling, but it's good to know that they've got someone in their corner who understands what their anxieties, and who will be there for them. So I think, and it's not just the friends and family, it's the churches, it's the mosques, it's the temples, religious, your faith intersects with how you get healing. For half the battle is in people who believe that I'm going to get better, and I'm going to go through this treatment, and I'm going to be okay. Someone who starts from, oh no, very negative, I don't think this will go well, they often don't do well. So faith is an important mix as well. So let's support people in their faith, let's support them in their families, let's, as friends, let's bring them up. The problem in the community is because a lot of people think it's a taboo, this person might die, they run away, they pull back. Then unfortunately, that person is isolated with all their anxieties, because everybody's not sure what's going to happen. No, let's support people. Let's surround them. It is okay for them to ask any questions they want to ask. There's no such thing as don't ask that question, or that's a silly question. Let them tell us what they want to know. I'm worried about work. I'm worried about pain. I'm worried about my daughter. And then in saying that, you might find the answers, because they don't know where the answers are. Once you ask us the questions, we'll say, yes, there's that support group. Yes, there is this medication, we can change it to. Yes, you don't need to go to work. We'll give you time off work. What are you worried about? So I think let's just be a listening ear. Let's be present. Let's not allow people isolate themselves. Let's support them in their faith. Let's support them with our presence. Let's just be there. Go to appointments with them. Listen with them, and let them tell us what they need. And that would be my approach.
Thank you very much. You're very informative and very understanding to, take it in. But my sister-in-law, who's been having this cancer treatment, is now, she's had her whole course of chemotherapy, but now her good side of the nostril for breathing, she can't do that. Now she's breathing from her mouth. So I don't know how often is this supposed to be successful or not, because it's affected her whole nose now, the treatment.
Okay. So I don't have the full details of this specific case that you're referring to, because the sort of information that we would look at would be what sort of cancer it is, where is it, what are the structures around it, what sort of treatment did she have, what are the side effects, because there might just be side effects of treatment with swelling in that area, or it may be that the cancer itself has already destroyed structures in that area. So it's difficult to say which is it, but I would encourage that you know, in the next appointments, you bring this up with your treating physician or oncologist, because it may be that, you know, there is examination needed or there's an extra scan needed. There's no such thing as a stupid question. Just ask the oncologist, I've noticed the symptom since the treatment. Is it a side effect of treatment, or is it that the cancer is doing something we haven't identified? Because if you don't speak up, they don't know that there's a new scan that's needed or a new endoscopy that's needed. So you know, that's how I would approach that. Just bring that up. Any concern, just bring it up in the appointments, and the team will decide if a scan is needed or if it's just reassurance that it's because of the treatment.
Thank you. She has had all the scans and everything, and I appreciate the way you explained to me. Thank you again. Very informative. Thank you.
Thank you so much.
Thank you for your questions. We've got a few minutes left. I'm just going to be passing over to Kirit shortly. I think you've got some background noise on there, Kirit. Okay, so Dr. Dejo, thank you so much for today. Obviously, the information you gave, you've read the chat. Everyone found it very informative. We will be definitely collaborating with you further in the future. I know Kirit's definitely got some things planned with you. I'm looking forward to obviously discussing some things around the oral cancer project that we've discussed earlier. We are looking for connectors to obviously join in the main part of this project. The reason EMCA, which is the East Midlands Cancer Alliance, and NHS have put together such a project like this is so that organisations like ourselves, Kirit, who's been working so hard with both of those organisations to put a project like this together, he's obviously set it up in a way where what we do is we keep something sustainable in the community. And I'm just going to quickly share my screen so I can just go through some of the leftover slides. It's just quickly to show. So one of the things, hang on, we'll just get to the right slide.
Most people. My name's. I'm Sadaf Magal.
These videos will be uploaded to our screens on YouTube and our channels. So please do visit them once we send you the link. You can go through all the different videos or any specific ones that you wanted to look at. Obviously, we went through why recognizing symptoms matter. So I won't go through that whole list, but it is there. We are going to be going through that in further detail. And with different cancers, there are different types of symptoms that you may get, as you will see here, especially for things like prostate, bowel, lung, breast cancer. There's usually different types of symptoms that you will see. For example, there with breast cancer, South Asian women, it says, are less likely to check breast regularly. Now, that is some information we've been given by the NHS, but we want to make sure that everyone's getting the same awareness and same education around things so that everyone can receive the same treatment. Again, as Dr. Dejo mentioned there, if symptoms are lasting 2 weeks and especially 3 weeks or more, you definitely need to get in contact with your doctor. Barriers faced by South Asian communities, things like the language barriers, fear of cancer, the taboos, some of them that we've discussed today through our guest speaker, Kamini, and as well, Dr. Dejo mentioned some of them. Also things like putting family first, ignoring your own health. What we want to do is recruit connectors, and that's the important part of this project. We need people like yourselves, volunteers in the community who are willing to be trained, work with specialists like Dr. Dejo and various other consultants and specialists that are on our team to become specialists in different areas of cancer, so that if people do come to us with symptoms, can't get seen by a GP, need support, again, like Dr. Dejo said there, going back to so many things that he said, because he covered quite a lot there, but one of the things that was important is to take someone to appointments with you, to have a list of questions that you want to ask, because sometimes in that moment, not everything might be clear in your head. So part of this connector's role is to be there. And there's a lot of people nowadays, families suffering from financial difficulties, not being able to take time off for numerous appointments. Our connectors' role is there to help support with that. So it's a huge role within the community, and it's something that we hope to train connectors on. It is one of the things that we are going to be starting in the first week of August. There's some details there. So just finally from myself, please come and join a growing network of people. We want to make change. You can contact us if you want to take a quick shot of that, or you can find it in the chat as well. It's connectors@sahauk.org. We've also got our contact number. You can WhatsApp us on there if you need the details and you can't email. But please do contact us. We need as many volunteers in as many communities around Leicester, Leicestershire and Rutland. So please do contact us, and we will be having our first training session in the first week of August, which we'll be sending details out to everyone who's interested very soon. I know we're very shortly running out of time, so I'm going to pass over to Kiri, and if there's any final words from Dr. Dejo as well.
You want me to speak, or because I do have one or two things just to...
Please, Dr. Dejo.
Please do. Carry on. I'm going to try and spotlight our breast consultant as well to come on. So she's going to be one of our October kind of guest speakers. So if you could just unmute your video, and I'm going to bring you as a spotlight as well. So thank you for taking time as well. So just a quick introduction about yourself, and then people who are still here will know to look forward to seeing you in October.
Hi, Kirit. Hi, Saha. Hi, everyone who has shown up today. Well, I wasn't expecting to say anything, but well, thank you. My name is Dr. Lubukalaya Dele. I'm the consultant medical oncologist. I treat breast cancer, and I head the breast cancer unit at the University Hospitals of Leicester. And as everyone has said, I'm really glad that Kamini shared her story and about how things work really well and how you need to come forward. I think it's no longer news that when it comes to talking about cancers in the South Asian community, that it's quite difficult because it's something nobody wants to talk about for different reasons that have been mentioned today. But I think the big work that's being done here is for how to change that, so a lot of work that will be done and that you guys are doing, Keval and all of you, is demystifying cancer, because I think the biggest issue is that people still find cancer a mystery. So I think it's the education and the literacy around it that's important. So so I'm looking forward to working with Saha. I've been to a few of the meetings already, so yeah, looking forward to doing that.
Thank you for putting you on the spot, but great to have you working with us as well. So over to you, Deji, for your final words.
Yeah, thank you so much. And thank you to Dr. Idele for the fantastic work she's been doing with raising awareness around breast cancers and reducing inequalities in both the Black and Asian communities in Leicester. It's been a privilege to collaborate with her and with Kirit and Saha. It's been a wonderful collaboration with the South Asian Health Action Group, I must say. You have been proactive, you're organized, you've had lots of evenings when we've sat down together, and you've actually given us a lot of information around how we can work with you. So we're really grateful to you all. You have people who have lived experiences, and so I want to thank Kamini for being brave and for sharing her story today around her experiences around the breast cancer and the treatment. And I think we just need more voices in our communities. We need more positive storytelling about our experiences with cancers. Let's demystify cancers. Let's talk about it. Let's break this culture of silence that means that people present late. It's just like any other illness. Let's come early. We would therefore have better treatments, and the survival will be better. You'll be able to have cutting-edge treatments if we pick something up early than if you come late. I think that's the main message today. And let's push towards prevention. If there are vaccines available that can prevent cancers of the cervix and of the throats and genital areas, let's encourage our children to take them, so that we are not left behind when 90% of the Caucasian population no longer see those cancers. It will be a real tragedy if there's a vaccine and we're not taking it, and then in several years, it's our children who are left having those cancers. And I think it will be good to continue the engagement work and work with SAHA and the other ethnic communities around raising awareness. We want you to lead the way, to co-design with us how we can work around the risk factors. For me, it's about how we can engage the Asian community on chewing pan, tobacco, gutka in a sensitive, culturally appropriate way. Because you know your communities better. Are there things we need to take out of pan to make it safer? I don't know. So we would need to work with you on that. And I think it's great work, and we're expanding our conversations because it's a two-way conversation around cancers, breast cancer, lung cancer, colon cancer, prostate cancer. The men don't want to talk about this. So we want to expand all of that and work with SAHA as we're doing with all the other communities. It's been a real privilege having me today. I've really enjoyed every minute of it. So thank you for your time.
Thank you, Dejo, and thank you, Duki, for your support as well. But I think one of the things that, and thank you for the people who've joined us. Keep just for another 5 minutes. I want you to just stay with us for another 5 minutes because our chair will do a final closing. But one of the key things that we would really urge for your support as consultants within the medical team is getting connectors to us, because up to now, all of the connectors you see as part of our network has come through outreach engagement, word of mouth, but no referrals from the hospital system. So that's something that we want to get right with this project, because that's the only way we're going to try and get more people with different cancers, but from different communities. So that's one of the things that we can work on going forward, because that's something that our strategic work with the Cancer Alliances, with the NHS, is about future outcomes and future opportunities to try and demystify what you're saying in terms of the cancer, the taboo, and the connectors are the right messengers. You know, they're the ones who've gone through it. They're the ones who have been able to suffer in silence, because these are the conversations we've had with our connectors. They've had no support. Even their mental health being has been not supported while going through their journey of their diagnosis. So how we can get that better is in ensuring that now we've got the system set up for this peer-led network. They're the right people who have now built a family, but they're also supporting each other. And as Keval said, you know, those people who can't find family support is something that we can offer. So that was one thing I'd like to say. Going back to the oral cancer, the pan, the kutka, it was just fortunate 25 years ago, I was, doing a similar project around pan, kutka, and we went back to India to an oral cancer conference. And then we went to our twin city of Rajkot, and it's now a pandemic of cancer, and we're just fortunate. I'm still connected with the consultant who was at the cancer hospital there. He's now running a cancer institute. So in terms of the messaging, the information, we can kind of have a good opportunity to kind of co-design that from back home, because they've got streams of years of working around this area. So again, that's a good knowledge that we can bring to the work that we're going to do. And finally, working with yourself, with Oracle, and obviously the City Council, health promotion team are really pushing this oral cancer work. So we're going to kind of continue that. Without further ado, I'm going to bring our chair. Keval, is there anything else you want to say before I just bring Nihina in?
No, just wanted to thank all the guest speakers, the consultants, Dr. Dejo, Kamini, Dr. Idali as well, everyone, basically, everyone who's joined us today. Thank you, everyone. Please do contact us. The email address are in the chat. Connect us at sahauk.org. We need people to be community connectors, and you're the people that can deliver that message the best. So please do contact us, and we can get a registration form out to you and let you know when the training is. Thank you.
Hina, can you start your video and I'll spotlight you? Great.
Good afternoon, everyone. To be honest, I just wanted to say a final thank you. I think everything that I wanted to say has already been mentioned, and I say a big thank you to everybody that's joined us today, because without you, this event would not be a success. We need you to take the information and pass it on to your families, to your friends, to anybody that that can benefit, really. And I think one of the statistics that's been shared sort of everywhere is that 1 in 2 people will get some kind of cancer at some point. Now that's half of the population, so it can be very scary. So it's useful to know what the signs and symptoms are and where to go, and what are the questions to ask as well with your GPs. So honestly, finally, just thank you, Dr. Oladejo. Without you, we wouldn't have this information. So thank you for giving us your time today. Kamini Ben, thank you. It's not easy to share your story as you did, and like you said, a lot of people sort of shy away or are afraid of cancer, and I think it comes down to fear because they don't understand what it is and what it sort of entails. So the fact that you've shared your story, it shows a lot of courage. So thank you. And definitely thank you to Kirit and Keval, because you guys have made this happen. Without the time and effort and all the work you've put in, this would not have been possible. So big credit to you both. And to get the best results, it is important to get an early diagnosis. One of my questions was going to be quickly to Dr. Oladejo is, how do you get your GP to take you seriously? Because initially it's difficult to get an appointment. And when you do get an appointment, how do you get your GP to take you seriously? Because I lost one of my cousins to bowel cancer about 3 years ago, and he was only 35 years old. So when he eventually went to the doctor, when he finally got an appointment, he was fobbed off for a long time. And what happened was his diagnosis was very late. So when he did get his diagnosis, he was already at stage 4, and he basically didn't have a lot of time left. So what can we do to be taken seriously by our GP?
Thank you so much, Hina, for that question, and sorry to hear about your loss. It's difficult to cope with, particularly when you look back and you think, maybe if this had been caught earlier. So condolences on that. Now, the GPs are doing incredible work, and they are super stretched. And we hear this conversation everywhere we go, that I can't get a GP appointment, and when I do see them, they say go and try this first and then come back, and I can't get another appointment. So the NHS is stretched, the system is stretched, but it's not just the GP, as someone has put in there. We can go through our dentists as well, they can refer in. From a conversation point of view, people need to become assertive about their symptoms and what they want. And one of the things that we did with the Afro-Caribbean community was the drama series, the Life Forum Theatre, where we showed people how to talk to their GPs, how to speak to their GPs, and how not to bury symptoms and talk about everything else and not the key symptom because they're worried about something. So I will say, now that we know what symptoms could mean that someone has a cancer, you go to the GP armed with those symptoms. You can go along with someone else as well, a relative or someone who can advocate for you more strongly. And you will say, I have a lump in my neck. I can't swallow. It's been over 3 weeks and I'm losing weight. I am worried this could be a cancer. Can you refer me as per the guidelines to the hospital team, please? There's no way, there's no getting around it. Because you've demonstrated that you know what the symptoms trigger a referral, you've told them you're worried it's a cancer, and you've come within the timeline. And not everybody should just go within 2 days of having a cough and cold. That will overwhelm the service. But you waited 3 weeks, you've had persistent symptoms, you've looked at what the guideline says, and you've shown that you know there is an urgent pathway, and you are confident enough to say, I am worried it could be a cancer, even if it is not. the GP will pay attention and refer you. So I think that is one way to get across, and go with someone as well.
Thank you. The drama that you referred to, I actually attended that. So I was going to say, if there is a recording of that, it would be great to be able to share that. So if you have that, please do pass it on to Kirit, and we can share that with all our members. And I think it's very important that we all work together and keep raising awareness of these issues. So thank you again.
Just a final comment from myself. I think we're kind of privileged and honoured to have Dr. Dejo in Leicester, and particularly also Ducky. These are, fresh blood consultants coming in, to a system that's been around for many years that, we haven't had much joy in terms of getting them out to the community. So it's refreshing to see consultants now in the UHL are changing the way they work. They're coming, their leadership team is really kind of coming forward and wanting to do more. So I have to acknowledge, and, just at a private message, I had one from a patient you treated last year. She was singing your praises because, she was treated by you, and she was really had nothing else but to say, really was thankful that you treated her and actually you operated on her. So look, for the guests, the people who attended today, let's have these conversations. The cancer conversation we're doing every month till March is about getting other communities on board. So we are going to be working with other community organizations. So our next event will be on the 23rd of August with the Dudley community. So that's going to be, we're going to send you a poster out, and those of you who haven't signed up, or you've got our email, so just drop us a line. We'll keep you and add you to our database. So on that note, thank you all for joining. I've kept you 15 minutes longer than I should have, but appreciate your time, and thank you for a wonderful World Head and Neck Cancer Awareness Day that's done justice to what we're trying to do. So thank you again.
Thank you, everyone. Thank you, Hina. Thank you. Thanks, Keval and Kirit. Thank you. Thanks, Kamani.
Thank you, Dr. Dejo.
Angalan, thank you all. Bless you.